Hello, everybody. Today, I'm going to be talking about reshaping the boundaries of negative pressure wound therapy in the treatment of acute and chronic wounds. I'm going to be talking about negative pressure wound therapy, new international consensus panel recommendations, and a clinical decision pathway, understand how you can use the different types of negative pressure, and as a result, hopefully improve your clinical, patient, and financial outcomes. As was mentioned, my name is Robert Kirsner. I'm the chair and Harvey Blank professor at the Dr. Phil Frost Department of Dermatology and Cutaneous Surgery, also a member of the Department of Public Health Sciences at the University of Miami Miller School of Medicine. And just as a disclosure, I am a paid consultant for Smith+Nephew, and I am presenting data that I was involved with, but also Smith+Nephew does not provide medical advice, and the presentation is not intended to serve as medical advice. So what I'm going to cover over the next 25 minutes or so are kind of three broad topics. The first is the role of negative pressure wound therapy and wound care. We're going to talk about environmental factors and practical considerations. I'm also going to then talk about traditional negative pressure and then a relatively new way of delivering negative pressure, single-use negative pressure therapy. And now that there are these two different ways to deliver negative pressure, really to understand what they are and how they fit into the continuum of care for a patient who needs negative pressure wound therapy. And then finally, I'm going to go over several different publications which you'll be able to download from the website after this presentation's over, talking about some data and then the consensus recommendations from a panel of experts to try to outline a decision pathway for how you might want to begin to think about how to use the different types of negative pressure for your patients. So let's launch into the discussion. So certainly we know that our world is changing. And as busy as we were yesterday or the year before that or the year before that, from all of us and as a society, wounds are just becoming a bigger problem. It's growing for patients, it's growing for healthcare systems, and it's also growing for society. And certainly over the last 15 months or so with COVID, this has even created more additional and perhaps unexpected challenges caring for patients with wounds. We know that wounds are widespread. There are many different etiologies of the wounds, and the wound often occurs by itself, but more often will occur in the setting of other medical problems that patient has, and often may be a result of a conglomeration of various comorbidities. As a result, these wounds can be quite challenging. Certainly, they impact a patient's quality of life. Their satisfaction when they see healthcare providers may be impacted. They hurt, and patients' function is affected. And on top of all that, on top of the patient costs, there's also healthcare system costs, and there's a financial cost associated with wounds that, in general, and especially those that are untreated or unresolved. Now, just to give you a taste of how ubiquitous, how prevalent wounds are. This is some data from the U.S., and it kind of mirrors worldwide data, but let me share with you some information about acute and chronic wounds. So certainly in the United States, it's a huge problem. 6.5 million patients are affected each year with the three most common chronic wounds that we see, the pressure ulcer, the diabetic foot ulcer, and the venous leg ulcer. And that equals about 1 in every 38 patients having a non-healing wound. Sometimes it's hard to get a sense of what that means, and those numbers may seem obscure and abstract, but really these are common. In fact, if you take a condition that we're all very familiar with, for example, heart failure, wounds are 11% more prevalent than patients having heart failure. And then if you look at the acute wounds in the United States, just a few years ago, over 17 million hospital visits were due to acute wounds in 2014. And if you look at one subset of that acute wound market, that's burn injury. 1.5 million was spent in burn injury care in 2010 in the United States. So all of this is to say that wounds are common, costly, and have a lot of negative effect on patients and society. Now, we have a lot of tools in our toolkit to care for patients with wounds. We want more. But one thing that we've used over the past 20 or 25 years is negative pressure wound therapy. And since its inception, its use has grown, and now it's the gold standard for many of the open acute and chronic wounds that we deal with on a daily basis. We've become used to calling on negative pressure wound therapy to help our patients deal with their wounds and help ourselves care for those patients. Now, what was original negative pressure wound therapy has now been retermed traditional negative pressure wound therapy, and you all know this. This is a system that draws fluid from a wound into a canister via tubing. It's most commonly driven by electricity, and it's often quite large and bulky and used for wounds of all sizes. But over the past 8 to 10 years, another type of negative pressure device has been developed, and that's a single-use negative pressure device. And that differs from the traditional negative pressure device in that it's a one-time application, so the product is used and then discarded. In one of the products, the Pico, uses a dressing system where a set level of negative pressure is applied through the wound, through a battery, and then the fluid is drawn into an integrated dressing. And that fluid is drawn into the dressing. 4 out of every 5 cc's, or 80% of the fluid, evaporates while the other 20% is absorbed in the dressing. And then at a period of time, typically more or less a week, that dressing can be discarded and a new dressing is used. So there's the traditional negative pressure and the single-use negative pressure wound devices. The single-use was initially conceived to be more convenient, easier to deal with, better for outpatients, and you'll hear some more data about this in a moment. So this is a picture of a traditional negative pressure wound therapy, and this picture really shows kind of the scope of what was normally done. So you have a very large wound, often an acute wound. It often may be highly exudative and draining. And because of the depth of wound, it's often packed. Sometimes it's packed with a foam dressing. Sometimes it's packed with a gauze. And then negative pressure is applied on top of that dressing, attached to the tube, and then fluid is drained from that wound into a canister. And as fluid accumulates, the canister can be emptied, and the whole dressing is usually changed every 3 days or so. And we're all used to this traditional negative pressure device that's been used for 25 plus years. This is a single-use negative pressure device. Some of you may be less familiar with it. There are various dressing sizes, but basically you take a wound that can fit underneath the dressing. There's a battery-operated device that gives negative pressure. And instead of having a canister in which the fluid drains into the dressing, of which some of it evaporates. And you can see that here have the dressing in place and how a wound originally started quite large, this leg ulcer, and then diminished with the single-use negative pressure device. Smaller, easier to carry around for the patient. You'll hear about patient data in a little bit. So why do we need 2 different types of single-use negative pressure? If negative pressure is so great, why do we even need another type of negative pressure, the single use? Well, Teresa Hurd and I recently published in the journal Wounds a paper that reviews this current negative pressure practice and identified certain challenges associated with these traditional negative pressure wound therapy pumps that are often in a hospital. And what we did was we identified kind of 3 different areas of challenges. We identified some clinical challenges in this paper. We identified operational challenges, and also we identified financial challenges that currently exist with traditional negative pressure wound therapy, especially those that are used in the hospital setting. So I'm not going to go into all of them. The paper, which you can download, is available from the Wounds International website. But just to highlight some things from that paper and some things from the literature, we certainly know that we really don't have great evidence to inform the appropriate and timely use of some of these negative pressure devices, and we'll talk about that more in a moment. It takes time for the clinician to apply these traditional negative pressure wound therapy devices, and it's not a simple task. People need training so that they can use it appropriately. So that takes time and training. These are big devices, and patients don't like them. They're noisy and heavy, and as a result of not only patient not liking them, it diminishes their quality of life, and patients may stop using it. In fact, 20% of patients who started on traditional negative pressure stop using it earlier than their caregiver would have liked them to use. And it restricts their daily activities. So they're not as functional. In fact, more than half of patients complain that they can't do what they normally would do because they're wearing this large, bulky, traditional negative pressure wound therapy device. Now, from an operational standpoint, oftentimes a hospital will have a fleet of devices. And managing that fleet takes time. In fact, over 5 hours, we're talking about more than 10% of one person's work we spend just on logistics and administration, according to some data in the literature. And when you have a large fleet, sometimes pumps are lost. In fact, 1 out of every 5 hospitals report losing pumps. Now, you have this big, heavy, bulky device, and it's in the hospital, and you're trying to continue it as an outpatient, and that makes discharge planning very complex, and as a result, increases length of stay, driving up costs for hospitals, and also, at least in the U.S., driving down margin. The billing is complex, and in fact, 1 out of 10 or 1 out of 9 bills that are submitted are actually disputed. And of course, all of this is on top of the clinical timing training I described previously as some of the challenges. And then finally, the financial costs associated with it, because when you have inefficiencies, whether they're inefficiencies in utilization, inefficiencies in maintaining the pumps, inefficiencies in billing, on top of the time and costs with regard to logistics and training, this results in financial challenges and financial loss. And then the transition from the hospital to the post-acute care is often challenging, and patients are doing well in the hospital but then can't be discharged because there's not a safe discharge plan. And we all are experiencing budgetary constraints. So these challenges exist. And what I'm going to suggest is that among the many benefits of the single-use negative pressure wound therapy device is the fact that it may deal with or help manage some of these challenges I've already pointed out. Okay. Now, to kind of put these two different negative pressure devices, the traditional and the single-use, into perspective, Teresa Hurd, I, and a group of international and wound care experts got together over a period of a number of months this past year and came up with an international consensus panel recommendations when to consider using negative pressure in acute and chronic wounds, and then decide which type of negative pressure device should they use. And again, this is published and also available on the Wounds International website for download after this presentation. Now, this consensus panel came up with 10 consensus statements, some related to therapeutic goals, some related to wound-related factors when considering negative pressure, others related to patient satisfaction and quality of life, others related to care setting-related factors, economic-related factors, and negative pressure device-related factors are part of this consensus statement. I'm going to review some of those documents and not give high details of all of them in great detail, but try to give you a sense of what that consensus document had in it. So the first set of consensus statements I wanted to share with you are those that the International Consensus Panel came up with related to therapeutic goals and wound-related factors. So the consensus statement, number 1, had to do with therapeutic goals, and it had consider initiation of negative pressure wound therapy when you wanted to promote granulation tissue, prepare a wound for closure, control edema, manage exudate, achieve wound stabilization, and assist in general stabilization of patients that may be unstable. Consensus statement 2 and 3 related to wound-related factors, and this includes thinking about wounds and deciding when they were appropriate for single-use negative pressure therapy devices, and that has to do with whether or not it met the device indications for use. Specifically, and I'll go through this in great detail, the wound size, the wound depth, and the amount of exudate would drive whether or not you choose a single use over a traditional negative pressure wound therapy device. And in the consensus statement 3, then also looked at the flip side of that, is when would you consider traditional negative pressure wound therapy? And once again, it's the size, the depth, and the volume that is beyond, volume of exudate that is, beyond which a single-use negative pressure can handle. And we'll go through an algorithm that was created in a moment to kind of highlight how you might begin to think about which one of these types of negative pressure would be used. Now, why should we even consider using single-use negative pressure wound therapy? Well, interestingly, in a study that I published as a lead author, a multi-center study, comparing single-use negative pressure device, the PICO device, compared to other traditional negative pressure wound therapy devices in venous leg ulcers and diabetic foot ulcers seen in an outpatient setting over 12 weeks, what we found was that single-use negative pressure therapy devices, the PICO device, was superior. Not equal, but superior to traditional negative pressure. So if you have the opportunity to use the PICO device, you should, because in this trial, it was better. It had a greater reduction in wound area. This was statistically significant, 73% compared to 31% complete reduction. There was a greater reduction in wound depth, 48% versus 12.7%. And there was greater complete wound healing in the single-use negative pressure devices. Also, it was easier to apply. So clinical outcomes for both the patients and the staff favored the use of single-use negative pressure devices. And as I'll show you, patient satisfaction favored this as well. So if you have the opportunity to use single-use negative pressure device, you actually want to try to use it because, at least in this study and in follow-up studies that were published in animal models which confirmed these results, you should try to use single-use negative pressure wound therapy devices. So how do you think about that? Well, this is a key slide. This is the algorithm of when you consider to use single-use negative pressure. And the first question you ask yourself is, can the wound that I want to treat fit, can the dressing cover the wound? If it can, then you say, okay, this may be a candidate for single-use negative pressure. And there are different size dressings, and you have to, obviously pick the size that's appropriate. If it's too big for the single-use negative pressure dressing, then you'd think about using a traditional negative pressure. Once that you know it fits under the dressing, then you ask yourself, what's the level of exudate? Is it low, moderate, high? If it's low or moderate, well, this is the amount of exudate the single-use negative pressure device can manage, and you would consider using it. On the other hand, if there's high exudate, highly exudative, then perhaps you'd use a traditional negative pressure. Now, if you pass those two hurdles, then you have the option with the single-use negative pressure device to use a filler or not to use a filler. And it turns out that if you don't need to use a filler, this is perfectly fine for the single-use negative pressure, in contrast to the traditional negative pressure where fillers are virtually used all the time. Now, whether you use single-use or traditional negative pressure and you use a filler, you have to decide whether you're going to use gauze or foam, and whether or not those gauze or foam will have an antimicrobial agent such as silver impregnated. So as you go through this tree, you'll decide, A, whether you'll use single-use or traditional based on the size of the wound, the amount of exudate. You'll decide whether or not to use a filler if you're using single-use, and if you're using a filler, whether it's single-use or traditional, whether it should be a gauze or foam or antimicrobial, and then you could begin your therapy. Now, moving on for this international consensus panel, other wound-related factors. The single-use negative pressure system can be also used for bolster dressings for patients that are receiving a split-thickness skin graft or an application of a skin substitute. So this single-use can be used for this situation as well. And the wound status, Consensus Statement 5 suggests that the wound status should be reassessed every 2 weeks during therapy. And if the wound started out being large and heavily exudative and you chose a traditional negative pressure, as it gets smaller or as the exudate starts to diminish, that's an opportunity to think about transitioning to a single-use negative pressure device. Moving on to Statement 6 and 7 in this International Consensus Panel document relates to patient satisfaction and quality of life. And this is important because as wounds become more ubiquitous, the age of patients with wounds is actually getting younger. So now wounds are being seen to a greater extent in working populations, and making sure patients can continue with their life activities is critical. So if you're choosing a negative pressure wound therapy device, not only for clinical reasons, but also for patient satisfaction reasons, quality of life and treatment compliance, if you can use a single-use negative pressure device as a first-line modality, you should try to use it, and that's Consensus Statement 6. While Consensus Statement 7 suggests that single-use negative pressure may be perfect for those patients who are ambulatory, would like to return to work, and it's because of its ease of use, may be better for patients who have challenges with follow-up medical appointments on such a regular basis because they're using traditional negative pressure. So let me just share with you a case study, and this is case studies that were provided for me, and I want to thank the author of these case reports. So let me go through these cases with you. So here's a patient with a large abdominal wound, and this is a perfect example of a wound that was too large for single-use negative pressure when it was first encountered. So traditional negative pressure was utilized, but as the wound got smaller, it could then be transitioned to single-use negative pressure device for convenience and follow-up care. Here, and you could see here the clinical benefits over time as the patient went from traditional to single-use, and how the wound continued to get better and progress with that transition. Now, I suggested to you that patients prefer single-use negative pressure, and here's the data to support it. We found this data both in our randomized controlled trial that studied PICO single-use negative pressure versus traditional negative pressure, and with regard to overall satisfaction, whether a patient would use again, how comfortable the device was, all of these favored PICO, And when they asked whether the negative pressure device interfered with mobility, reduced activity, or disrupted sleep, PICO also had a less interference with mobility, less reduced activity, and less sleep disruption. In a separate study of 326 home care patients treated with PICO single-use negative pressure wound therapy device, nearly 98% were pleased with the treatment. Almost all of the patients did not report discomfort during wear. 19 out of 20 patients could perform their daily activities, and 9 out of 10 were able to shower while they had the single-use negative pressure device on. So it's highly satisfying for patients to use it and preferable to traditional negative pressure wound therapy devices. Now here's an example of a patient that maybe would have had a traditional negative pressure device put on in the past. This is somebody who had an emergency appendectomy. They had a gravid uterus and they had a protuberant stomach. They were 28 weeks pregnant. And because of the protuberant stomach, the wound dehisced, and you had a dehisced acute wound. Because this patient also had a young child at home and didn't want to stay in the hospital, and because the wound was of size and amount of drainage to use a single-use negative pressure device, that was applied, and the patient was able to not only manage the wound at home, the wound healed very quickly and actually healed very nicely from an aesthetic standpoint. And then when the patient finally gave birth to their baby, the wound remained healed during delivery. Moving on to several of the remaining statements on economic and care setting related factors that this international consensus panel addressed. Consensus statement number 8 suggested that traditional negative pressure wound therapy device should be used for patients with acute or chronic wounds that are large and complex. If patients can be transitioned from traditional to single use, they should be. Or you should start with single use if you can, and especially when patients are transitioning from inpatient to outpatient care. Consensus statement 9 said the application of single-use negative pressure as initial negative pressure modality or as conversion from traditional negative pressure wound therapy also has financial benefits. That is, it reduces overall healthcare costs and assists in the transition of inpatient and outpatient care, thus reducing the length of stay and not having to keep a patient in the hospital just to receive the negative pressure because you don't have a good alternative as an outpatient. And as an example of this situation is this abdominal surgery wound in this patient. The patient had abdominal surgery, started on negative pressure. The patient wanted to go home, and because the wound had improved enough to fit under a single-use negative pressure, the patient was able to transition and continue to receive care and heal the wound as an outpatient. A perfect example of how a very nice and rapid transition can occur. It turns out that the PICO dressing has a mean wear time longer than traditional negative pressure, so that it's easier to apply. You have to apply it less frequently, and thus it has reduced healthcare costs. Because of the use of single-use negative pressure, in fact, this idea that you could discharge patients earlier, have better outpatient care, improve quality of life, and reduce costs, all have been proven to be true. In fact, if you look at PICO versus traditional negative pressure devices, you have over a 6-month course of care, nearly a $16,000 cost saving per patient. And because of the faster healing over that 6-month period of time, patients had open wounds nearly 5.5 weeks shorter than with traditional negative pressure wound therapy devices. So I shared with you some ideas about negative pressure. I talked about the different types of negative pressure and the value of single-use negative pressure. And just to remember that negative pressure is a great therapy. And if you use it appropriately, you can improve clinical and patient outcomes, you can improve operational efficiencies, and for inpatients, quicker patient discharge. And as a result, not only will you and your patients benefit, but there'll be cost savings and optimized resources for your healthcare system. Thank you very much, and I look forward to answering any of your questions. And don't forget to download the documents on the WINT International website that contains all of these great papers. Thank you.